Welcome to the next installment of the American Acne and Rosacea Society Audiopearl. I'm Lorraine Rosamilia, dermatologist with the Geisinger Health System, working in State College, Pennsylvania. I'm also on the education committee here for the AARS. And joining me today are Douglas Fife of the Surgical Dermatology and Laser Center in Las Vegas, Emmy Graber, dermatologist practicing in Boston, Massachusetts, and Sewon Kang, professor and chairman of the Department of Dermatology at Johns Hopkins. Welcome, everyone. Our topic today is acne scarring, and today we're going to hear about several perspectives. So firstly, I'd like to ask each panel member about a typical acne scarring patient that may come his or her way, as I think each of you likely has a different practice setting and demographic. So firstly, maybe Dr. Kang, what's your practice setting, and from an acne and acne scarring standpoint, what's your usual type of day?
Sure. So I do see some general derm patients, although many of my patients are skin cancer patients. But I think acne scars or patients with acne scars present in a multitude of ways. You know, there are those who come in specifically for that condition, and then there are those who may come in for some other reasons, and it becomes very apparent that that's a major issue they have. And then I would also say that there are folks who are young who may be going through active acne at the moment, and you see mixed along with active lesions, presence of scars already at that early stage of acne.
And Dr. Graber, is there any particular type of acne scar patient that you particularly look forward to treating, or if there's a combination of scar types that you typically see?
Yeah, I think that anybody with acne scars that they're concerned about, I look forward to treating, because a lot of them we really can help. I think it's interesting. A lot of patients will come to me and they'll say that they would like treatment for their acne scars, but still really have a lot of ongoing acne issues that we need to treat as well. And I prefer to treat the acne scars once we get the acne more under control. But I think a lot of the dyschromias and discolorations from acne that patients call acne scars, even though we know some of those discolorations may not be permanent, it's nice to treat those because they're very anxious to get the discoloration to go away.
And Dr. Fife, in your procedural practice, what kind of acne scar patients come your way?
Well, my practice focuses on skin cancer, laser medicine, and acne scars, so I'm seeing at least one patient a day specifically for acne scars. So I see a variety of patients. Some of them have deeply atrophic acne scars. Some of them have minor textural irregularities. Some have rolling acne scars. So there is a really great variety in the presentation of acne scarring. That's what makes it very difficult to treat. You know, we really have a tough problem here because patients are, number one, very concerned about their scars. When they look in the mirror, that's all that they see. It's very psychologically distressing, but also they're very difficult to treat. There's different varieties, and different types of acne scars require different treatments.
So let's get down to different acne scar types as of it. When some of you get referrals for acne scarring or for managing acne itself, but the patient expectation is that a laser or a peel or a filler will be a bit of an eraser, which we all know is not true, and that the expectations have to be managed. I think it would be helpful to describe maybe the scar types and what you would do for them. And so, I just had a patient this week who had some pretty extensive milia-like scarring, mostly on the trunk. Is there anyone who would like to particularly comment on the milia-like scars?
Sure.
Well, I will say that scars on the trunk, acne scars on the trunk in general, are very difficult to treat and very resistant to treatment. So I try to paint a realistic picture to the patient with scars on the upper chest and back. I have not seen those respond well to treatments. Not that we don't try, the patient's motivated, but it's much easier to treat hypertrophic scarring on the trunk than it is atrophic scars.
What about you, Dr. Graber? What about truncal scarring in your practice?
Yeah, I think truncal scarring is always very difficult because it is slower to heal, particularly with the more aggressive ablative lasers, and I think it's also very difficult to treat. And I completely agree. I think atrophic scars on the trunk are very, very difficult to improve, and even those milia-type scars that you're referring to are difficult to treat. I think, yes, the hypertrophic, very erythematous scars that are on the trunk can be improved, but aside from that, I think truncal acne scars are very hard to improve.
Yeah, and I find that even after isotretinoin, certainly there are situations where the face does so well and you think that, the scar situation is much more manageable and trunk remains, more of the challenge. But up on the face and the neck, what about some of the more superficial scar types? So some that, patients come in and they see, a bit of a textural change or atrophy, particularly on the temples and the forehead. Dr. Fife, how would you approach those usually?
Well, for atrophic acne scars, it really depends on the quality of the scars. If we're talking about superficial texture irregularity, maybe there's punctate scars or sort of superficial boxcar type scars, I think resurfacing techniques are great, be it ablative laser or cross chemical peels or fractional radiofrequency. The types of scars that I think are easiest to improve would be rolling acne scars, where there's really good skin quality and good pliability of the skin. Especially when these are long-lasting scars and they're soft. So soft tissue augmentation fillers with hyaluronic acids, or now with availability of polymethyl methacrylate, permanent filling, you can get longer-lasting improvement of those types of scars.
And in terms of an approach for some of the deeper, say, colloquial ice pick scars and things like that on the cheeks, Dr. Graber, what's your approach for those?
Yeah, I think that those are difficult. Some of the laser modalities that work so well for the other types of atrophic scars, I find it's not as impressive for treating the ice pick scars. I do think that the cross technique is helpful for the ice pick scars. It's something that requires a lot of patience on the part of the patient and the physician, because it usually does take several treatments to improve the ice pick scars in that manner. And also the treatment itself can be a little bit tedious, and you have to be extra careful just to be placing the trichloroacetic acid right in the actual scar and not in the surrounding skin. But I think when done correctly, the cross technique can be very effective for ice pick scars.
And when we're perusing literature, it seems like fillers are coming up more and more when it comes to innovations for acne scar management. Are there any that are exciting to you guys that you've been either using or trying out in studies?
Sure. Well, I can talk about that a little bit. There's actually something newer that's come out that's been published that I have not tried yet, but I'm looking forward to trying it. And it's the combined approach of using an ablative fractionated laser, like the carbon dioxide laser, and then applying a filler, specifically polylactic acid, to the surface and letting it kind of penetrate into the skin through those channels that were created by the laser. and then improving the atrophic acne scars. And it's a form of laser-assisted drug delivery that's been looked at before in combination with the carbon dioxide laser and topical steroids for treating hypertrophic scars. And now there's some evidence that using the fractionated carbon dioxide laser plus applied to the skin, polylactic acid, can be very effective for atrophic scars. So I'm really looking forward to seeing some more research about that and perhaps using that technique in the future.
And from your perspective, Dr. Kang, from medical dermatology, we're preparing the patient for, what their expectations should be about scar therapy. What's your opinion about when to time when a patient should have a cosmetic consult or a consult for procedural work in terms of their acne scarring when it comes to, post-treatment, especially with isotretinoin?
Okay, so let me perhaps start with the first question. I think as we are actually learning more about the natural course of acne scarring, one of the things that has become apparent to me is that although in the past we had this notion that once a scar is established, it's kind of a static lesion, but we are finding that there is some change over time. So I think especially those who have ongoing lesions, it's imperative that you treat the active lesions aggressively, because I think in addition to treating those that are apparent to both the patient and the physician, kind of trying to prevent the new ones from happening is important. I think for the kind that are large and well established, that the procedural dermatologists these days are really good at taking care of, I think using those fillers and various types of lasers are important. I would add to the comment that was just made about combining laser with something like filler. I think people are interested in combining procedures with pharmacologic agents as well. So at the recent World Congress of Dermatology, there was a presentation made that especially for the atrophic acne scars, at least in one pilot study using topical retinoid may provide some benefit. It's kind of a similar idea as improving photoaged skin, which is atrophic in nature. With topical retinoid, perhaps you could use a similar pharmacologic agent to basically lay down more dermal matrix and hence improve the undulation on the surface. So I think there are newer approaches, perhaps using older agents that were at our disposal, but perhaps using it in a slightly different way. As to when to refer to cosmetic dermatologist or procedural dermatologist, I think if the scarring is significant enough that in my opinion, no topical medication will really rectify the situation. I often refer them to my colleagues who do procedural derm.
And from either basic science or in your experience or clinical research, would you say that there's any medical innovations on the horizon that are not procedural in terms of things being either better or more curative than isotretinoin, or anything else in terms of acne scarring and new research that you'd like to comment on, Dr. Kang?
Yeah, I would say, a way to think about acne scar formation is kind of, localized, meaning the location is limited to sebaceous follicles. So these very localized areas of skin remodeling. And in terms of what's going on at those substructural areas, it's really no different than wound healing process that goes on in someone's lower leg. It's just we and others have shown that there's a boatload of enzymes that will degrade your dermal matrix. So I think an exciting area that some companies are looking at is using various inhibitors of these enzymes, kind of like the class of tetracycline that have the MMP inhibitory activities. And of course, if you're dealing with an atrophic situation, any agent that can potentially boost, fibroblasts to make more matrix components ought to improve the situation. So I would say that down the road, there ought to be newer agents that we don't currently have that should become available to help our patients.
And Dr. Fife, what innovations are you passionate about when it comes to acne scarring, or what kinds of things are you doing in your practice that are new?
One of the things that I've done in the last few years is added punch grafts to my treatment of ice pick acne scars. These are scars that are very difficult to treat, and when I look at ice pick scars, I'm thinking of three possible procedures. One is the cross chemical peel, which someone mentioned, where we deliver 80 to 100% trichloroacetic acid directly to the base of the scar and the walls of the scar with a toothpick or with a really fine tip paintbrush. So that's one option, is the cross chemical peel. Number two is a punch excision or a small elliptical excision and a closure. Number three is the punch grafts. And when I see a patient with a lot of deep ice pick scars, I often will do a test spots where I treat one with cross, one with excision, one with a punch graft. And I've been very surprised in the last year or two where the punch grafts tend to do better than all of those. It's a one-time procedure, and as we do a lot of punches in dermatology, it's not that difficult of a procedure to add to your practice. The technique is described in some publications, but essentially it's harvesting a graft behind the ear. It's punching out the scar with a punch of the same size or maybe slightly smaller diameter, and then placing the graft in the wound created where the scar was, and simply putting a steri strip over it. So that's something new I've added to my practice. In the last couple of years, I've been pleasantly surprised with the results.
So what size punches are you usually using?
What size of punches am I using?
Mm-hmm.
Well, it's typically 1.5 to 2.5 millimeters punch. So it's difficult to. I haven't done any punch grafts larger than 2.5 millimeters. I think it works best for the ice pick acne scars that are small. And so it's typically a 1.5 millimeter punch or a 2 millimeter punch or a 2.5 millimeter punch. So these you can buy these disposable, or there's reusable kits that you can use. One thing I have noticed about patients with boxcar type or ice pick acne scars is some of these patients can be poor healers. So when scars are excised with punch excision or mini elliptical excision, and they're sewn up perfectly well, sometimes the scars just become atrophic again. But I found with the punch grafting that this doesn't happen, the residual or recurrent atrophy after a excisional procedure.
And do you tend to do maybe one at a time as a test, or do you do a couple at a time?
Yeah, I'll typically do one or two as a test, and I'll do a couple lesions with cross, and I'll do one excision, and then I'll see how they do. So yeah, once the scars are shown to improve with a certain procedure, then I'll go and treat all the scars with whatever procedure seems to work the best.
And any last thoughts from you, Dr. Graber, to share with the AARS about acne scarring or the way you treat acne scars in your practice?
Well, I think we touched on the most important point at the beginning, but it's really about setting patient expectations for a realistic outcome so that everyone is on the same page from the get-go. I think, like you mentioned, people think that lasers are an eraser of sorts or even a magic wand and that it's going to work with just one treatment and things are going to be perfect. But I think that we need to set up our patients' expectations at the beginning so that it's successful for everyone involved.
Thanks so much. I want to thank our expert panel for their time and thoughtful responses on such an important topic that no matter what our practice setting certainly affects us on a daily or weekly basis, and we certainly all benefited from your opinions. Thank you so much.
Thank you.
Thanks.